guys, this is the NCLEX RN Pediatric Review video. Growth and development. The motor reflex is a startle reflex. So if you bang on a table, the child will startle and pick their hands up, It should be present at 3 to 6 months. If it's not present within these months, then it could indicate brain damage or spinal cord damage. The baby's first food. So this should be given at 4 to 6 months. You want to start off giving iron-fortified cereals. Every time you introduce a new food, you want to wait 5 to 7 days in between to see if they have a reaction. Then we go on to puree foods. This occurs at 6 to 8 months. After you give them puree foods, then you could give them finger food, Cheerios and stuff that they can use with their finger. Cow's milk is given at 1 year old. The first dental visit should be within 6 months of the first tooth or by the first birthday. Bladder and bowel sphincter control. So this happens at 24 months. So that's around the age that's 2 years old where you would toilet train a kid. Toddlers start at 2 years old. For toddlers, the chest circumference exceeds the abdominal circumference, so it causes them to have a more taller and slender appearance. The head circumference increases by 1 inch during the second year, and then goes 1.5 inch per year until 5 years old. The toddler should gain weight about 4 to 6 pounds a year. By 30 months, which is 2.5 years, the toddler should weigh 4 times the birth weight. There's such a thing called physiological anorexia. This is a decreased appetite that commonly occurs with toddlers. They just don't want to eat, they're not interested in eating that much. You want to give them multiple food options and set a schedule for meals, no TV while watching, and do not force them to eat. This is completely normal. Separation anxiety. So this happens at 6 to 30 months. So they go through 3 stages. The first one is protest. The child refuses to go to anyone else, screams for their parents, keeps crying, etc. Then we go on to disappear. The child is quiet, withdrawn, and not interested in playing. It might go back to younger behaviors like pacifier, bedwetting, etc. The next stage is detachment. In this stage, the child is happy and interested and plays. The nurse's intervention for separation anxiety. So you want to build trust with them first and then a connection with the family members and with the child. If a child's in the hospital, you want them to have memory of their family and their home. So you want to bring them toys, books, pictures, etc. from home. You want to establish a daily schedule that's very similar to their home. So if they go to bed at 8, you want to try to put them to bed around then. And you want to give them some opportunity to play, give them activities and games, etc. Congenital heart diseases. These are heart diseases that a child is born with. Start off with tetralogy of Fallot. So this is a complex heart defect that causes 4 different heart diseases. So tetra is 4. It causes decreased pulmonary blood flow, mixing of oxygenated and unoxygenated blood, and not enough blood flow to the left side of the heart. So basically what's happening is that there's not enough blood circulating and going around the whole body and the heart. Signs and symptoms that are specific for tetralogy of Fallot are hyperstenotic episodes called TET spells. They could also have other signs and symptoms like clubbing of fingers, irritability. Signs and symptoms are that they're not getting enough blood flow. For a child with tetralogy of Fallot, it is normal for them to have an O2 sat of 65 to 85 until they have surgery. So if you have a question that they give you a child with tetralogy of Fallot, and which one do you see first, if the O2 sat is between 65 and 85, that is completely normal for them. That will not be your first pick. So the TET spells occur in stressful or painful procedures when they walk, they're hungry, they're crying, they're feeding, etc. The first thing you want to do is a knee to chest position. You always want to think TET spells, knee to chest position. So interventions. So you want to maintain a calm environment. You want to soothe the infant, give them a pacifier, swaddle them, hold them, and you want to give them frequent small feedings. During an acute TET spell, like we said, you want to place them in a knee to chest position, and for older children, they squat. Atrial septal defect. This is an abnormal opening from the right and left atria. So because there's an opening, so the blood keeps flowing from the right and left atria to equalize itself. This back and forth causes a vibration, so when you auscultate them, you're going to hear a murmur. Signs and symptoms are going to be a systolic, because it's atria, murmur, and a fixed split-second heart sound. And they're going to be acyanotic. They're not going to be blue. Ventricular septal defect. It's the same thing, just in the ventricle. So there's an opening between the ventricles instead of the atria. It causes a left to right shunt. So a lot of blood is going to flow to the lungs. So you're going to have pulmonary congestion. So the patient's at risk for heart failure, pulmonary hypertension, etc. Signs and symptoms are going to be a harsh systolic murmur that's going to be auscultated near the sternum vertebra at the 3rd or 4th intercostal space. And they're also going to have classic heart failure symptoms, so tachypnea, dyspnea, diaphoresis, etc. Here are more congenital heart diseases. coarctation of the aorta. So this is when the aorta is narrow at a certain point. So if you think of it, if you squeeze a hose, you're going to have less coming out. So there's less cardiac output coming out. The aorta's job is to bring blood to the rest of the body. So signs and symptoms are going to reflect this. You're going to have a weak lower pulse and a strong upper pulse because the lower body's not getting enough blood, but the upper body has. The next disease is patent ductus arteriosus. So the ductus arteriosus, it should close when the child's born. If it doesn't close, like here, it's patent, it's open, and the blood shunts from the aorta back to the pulmonary arteries. Signs and symptoms are going to be systolic murmur with machine-like sound. So that's how they like to phrase it, machine-like sound, and poor feeding. It usually resolves within 48 hours and does not need intervention. But if it does not, intervention includes surgical ligation or IV indomethacin to close it. Next we go on to pulmonic stenosis. This is when the ventricles are trying to push blood through a narrow pulmonary artery to the lungs. So it causes increased pressure in the right side. Signs and symptoms are going to be a loud systolic ejection murmur, and it's going to be a cyanotic thing. So they're going to be blue, etc. Treatment. So treatment is balloon angioplasty. So they're going to open it. You want the child to be NPO 4 hours before. You want to report a diaper rash to the healthcare provider because this could delay the procedure. Because it's inserted femorally, a yeast or bacteria could be in a diaper rash and enter the bloodstream. Next we go on to mitral stenosis. What you want to know for this is that the sign and symptoms is going to be a diastolic murmur, not a systolic murmur like the other ones. Congenital anomalies. These are birth defects. The first one is trisomy 21, also known as Down syndrome. The major risk factor is getting pregnant at an older age, so 35 or above. Signs and symptoms that you're going to see on the baby are a single crease across the palm, short neck with excess skin, which is called nuchal fold, and cardiac defects are very common with children with Down syndrome. The next one is trisomy 18. It's also called Edwards syndrome. So this is a life-threatening chromosomal abnormality and affects all different organs in the whole body. Usually they die in utero or within the first year of life. There is no cure for this. What the nurse should do is that they should request a collaborative meeting with the healthcare provider. Next we go on to cleft palate. So this is an opening, which is also called the cleft, in the mouth that goes up to the nasal cavity. So the baby has difficulty sucking and feeding. The infant cannot create a suction or pull milk from the bottle, so they're at risk for aspirations and not enough nutrients, etc. So what they're going to do is they're going to have a surgery between 6 to 24 months. And until 6 months, so until it's repaired, you want to hold the infant in an upright position. You want to tilt the bottle so the nipple is always filled with formula and put it down away from the cleft. You want to use special bottles and nipples, including cross-cut and preemie nipples, and squeezable bottles. You want to burp the infant often and feed them every 3 to 4 hours over 20 to 30 minutes because it's too tiring to feed them more than that. Okay, after the surgery, you want to do pain management. So you want to soothe the infant, etc. You want to place the child in upright position to prevent airway obstruction. You want to use elbow restraints because you don't want the baby to pull on the cleft lip. And you want to monitor the skin and neurovascular status. Do not place hard objects in the mouth like pacifiers, straws, tongue depressors, or utensils. Developmental dysplasia of the hip. It is a hip abnormality that can be presented at birth or during the first few years of life. It is a standard assessment nowadays to screen for it for newborns and infants. So risk factors are breech macrosomia and a family history of it. To reduce the risk of getting it, you want to basically put the baby somewhere that their knees are not together or narrow. So you want to properly swaddle them with their hips bent up in flexion and out in abduction. You want a car seat with a wide base. You do not want like narrow infant swings or bouncers because it causes the legs to be straight together. It's diagnosed through the Barlow and Ortolani maneuvers, which is only to be done by a doctor, not a nurse. Signs and symptoms of developmental dysplasia. So in infants under 3, they have extra-inguinal or thigh folds, laxity of hip joints on the affected side. And if this is not treated by 3 months, then they disappear these signs, and when they're more than 3, they get different signs because of muscle contracture, like limited hip abduction, affected leg could be shortened, notable limp, they walk on their toes, they could have a positive Trendelenburg sign, and if it's bilateral, then the symptoms could also like wagging gait and severe lordosis. Treatment. So treatment is non-pharmacological for the first 6 months, like a Pavlik harness or cast. If that doesn't work, it goes to surgery. Pavlik harness. This keeps the hips in a slightly flexed and abducted position. It is worn for 3 to 5 months, and you want to regularly assess the skin. You want to dress the baby in shirt and knee socks under the harness. You do not want to put lotions or powders under. You want to lightly massage the skin. And you want to put the diaper underneath the straps, and only one diaper could be worn at a time. The harness is worn all the time. It could be removed once a day to bathe, but otherwise it is kept, even for diaper changes. Pyloric stenosis. This is when the valve between the stomach and small intestines gets very thick and narrow. So these signs and symptoms come 2 to 8 weeks after birth, not when they're right born. Signs and symptoms are very specific. So projectile vomiting, and then they're like really hungry. They have an olive-shaped mass, and you could palpate it in the epigastric area right above the umbilicus. Emesis is non-bile, so their vomit is non-bile, and they're dehydrated because they keep vomiting. Signs and symptoms of dehydration, like sunken fontanelles, decreased skin turgor, delayed cavity refill, etc. The next one is Hirschsprung disease, which is also called megacolon. So this is when a section of the distal part of the large intestines are missing the nerve cells. So there's no movement, there's no peristalsis, and the stools are not passed. Signs and symptoms. So they're going to have a distended abdomen. They're not going to pass the meconium within the 24 to 48 hours. They're going to have difficulty feeding. They're going to vomit, green bile, and they're going to have a ribbon-like stool, like they're really, really, really constipated. Complications. So this could cause enterocolitis, which is an inflammation of the colon that could lead to death. So some patients will require a temporary colostomy. The next one is intersusception. So this is when one part of the intestine prolapse and telescopes into another part. You know how a telescope one goes into other one? That's exactly what happens with intestines. One like kind of telescopes into other one. And it blocks the passage of intestine's contents, so it's interrupting the blood supply and causes intestinal tear. It is an emergency because it could lead to peritonitis. Signs and symptoms. The pain is very severe, it's progressive, and they have inconsolable crying. You can't do anything, they just keep crying because it's causing a lack of blood there. Other signs and symptoms, they have bloody current gel stools, so it's a mix of blood and mucus, sausage-shaped right-sided mass with palpitations, so it causes like bilious non-projectile vomiting. So with pyloric stenosis it was projectile vomiting, with intersusception is non-projectile vomiting, and intermittent pain. So the patient's going to like draw their knees up and be an inconsolable crying. It's going to be diagnosed through contrast enema, which is an ear enema, and that is also the treatment for it. So when you're giving the saline or ear enema, you want to monitor for normal brown stools, which means reduction in intersusception, that your treatment's working. Other congenital anomalies. Spinal bifida occulta is a neurotube defect. It's when the spinal vertebrae does not close during fetal development. So it could allow the spinal cord to protrude through the opening. There's different forms. So the most mildest form is spinal bifida occulta. The newborns could have no impairment or no neurodisturbances. Signs and symptoms of spinal bifida occulta is a tuft of hair, hemangioma, nevus, or dimple along the base of the spine. Open spinal bifida, which is also called myelomeningocele, is when the spinal cord comes out. This patient is at high risk for infection, so the priority is you want to cover the area with a sterile moist dressing and place the patient prone with the face to one side. Cerebral palsy. Cerebral palsy is a congenital muscle and movement disorder. Signs and symptoms: spasticity and clonus. Clonus is a series of involuntary, rhythmic, muscular contractions and relaxations. These patients will have baclofen pump. This helps control the muscle spasms. So if there's an increase in muscle spasms, that means that there's a problem with the pump. You do not want to stop the baclofen pump abruptly. Here are acute conditions. These are GI disorders. The rotavirus. The rotavirus is spread fecal-oral, so through food, toys, diapers, hands, etc. Signs and symptoms are watery diarrhea for like 5 to 7 days, fever, vomiting, and it's foul smelling. So you want to prevent this by hand washing, vaccinations before 8 months, etc. The complications are that it could lead to dehydration because they have really watery diarrhea. The next condition is hyperbilirubemia. So this is when there's too much bilirubin. The treatment for that is phototherapy. What phototherapy is that it's using fluorescent lights to treat the jaundice or hyperbilirubemia in the newborn. The light converts the bilirubin to a water-soluble form so it could be excreted in the stool or urine. What you want to do, you want to place the newborn under the light with only the diaper on. No lotions or ointments. You want to only remove the newborn from the light for feedings. They will need hydration because they're under the light. You want to monitor the temperature, and it should be low heat. The next condition is appendicitis. The appendix is located at the junction of the small intestines and beginning of the long intestines. When it gets obstructed from a fecal matter, it causes it to become inflamed. Signs and symptoms: right lower quadrant, continuous pain, tenderness at the McBurney point when you apply pressure, and rebound tenderness when you release the pressure. And other signs are nausea, vomiting, and high white blood cell count, and abdominal gardening. They're going to hold in, like they're trying to show their abs. The inflammation causes swelling and ischemia. If it is untreated, the appendix can rupture and release bacteria into the abdomen cavity, causing peritonitis and sepsis, which is an emergency. So if this happens, they will not have pain for a little bit. So if someone says they don't have pain anymore, that might not be a good sign. Treatment for appendicitis is surgery within 24 hours. You want to have them on fluid restriction with IV crystalloid, like normal saline or lactated Ringler. You want them NPO, and you want to give them pain medication. You want to avoid increasing blood circulation stuff like heating pads or a warm blanket on the abdominal cavity. The next acute condition is necrotizing enterocolitis. This usually occurs in preterm infants because their GI tract is immature. So when you feed them, bacteria can enter the bowel and proliferate, which could lead to inflammation and ischemia, necrosis of the intestines. Signs and symptoms: fever, lethargia, explosive and foul-smelling diarrhea, and rapidly worsening abdominal distension. What you want to do for them, you want to measure the abdominal girth every day to see worsening gas swelling. You want them NPO, and you want to do a nasogastric suction to decompress the stomach. You could do parenteral hydration, nutrition, and IV antibiotics. You want to place them supine and undiapered. Acute conditions with the urinary disorders. Nephrotic syndrome. This is when there is a change to the glomerulus that leads to massive amounts of protein leaking into the urine. The four classic signs and symptoms you're going to have is massive proteinuria, hypoalbuminemia, edema, and hyperlipidemia. What you want to do for this patient, you want to monitor fluid status and swelling, eye and nose. You want to monitor the urine for protein and limit sodium. And remember, they're at risk for infection. The next condition is glomerulonephritis. This is an inflammation of the glomerulus that leads to red blood cells and mild protein leaking into the urine. So nephrotic syndrome was massive protein in the urine. Glomerulonephritis is red blood cells and mild protein in the urine. Causes for this is a strep infection. Signs and symptoms is periorbital and facial or generalized edema, hypertension, oliguria, hematuria, or tea, smoky, rusty, or cloudy urine. Treatment for this. So they will usually recover spontaneously. So you just want to monitor the blood pressure and fluid status and avoid high sodium food, so no added salts. Complication is severe hypertension. So with this patient, you're really going to focus on the blood pressure. UTI, urinary tract infection. It is also called cystitis. Causes are bacteria like E. coli. UTIs are classified according to the location on the urinary tract. So if the bacteria travels up to the urethra, then it's called urethritis. If it travels to the bladder, it's called cystitis. And if it extends all the way to the kidney, it's called pyelonephritis. So signs and symptoms of cystitis, which means that it traveled to the bladder. It causes burning with urination, so dysuria, urinary frequency, urgency, hematuria, and suprapubic pain. Signs and symptoms of pyelonephritis, which means that it traveled to the kidney, is urinary frequency, urgency, nausea, vomiting, fever with chills, fling pain, CVA tenderness. It can also lead to sepsis. To prevent it from getting to sepsis, you want to take all the antibiotics, even if you feel better. You want to increase your fluids. You want to avoid every 2 to 4 hours, and you want to wipe from front to back. And you do not want to be wearing synthetic fiber material underwear like nylon or spandex. Acute conditions, respiratory disorders. Tonsillectomy and adenoidectomy are very common, which means that you're removing the tonsils or the adenoids. Post-op instructions. So post-op, the patient is at risk for bleeding up to 14 days after the surgery. And the bleeding could be life-threatening because the airway is compromised. So you do not want to turn to strenuous activities for at least 2 weeks post-op. Signs and symptoms of hemorrhage. Restlessness, frequent swallowing, which is the main one, or they're clearing their throat, vomiting, they're vomiting blood, and pallor. If the bleeding continues, the patient should be seen immediately and may need surgery to cauterize the bleeding vessels. You want to tell the patient to limit coughing, gargling, or clearing of the throat, or blowing the nose. You want to limit the physical activity, and you do not want to have milk products because it causes you to clear your throat. Don't drink through a straw or suction. Don't gargle. No oral mouth rinses. No vigorous toothbrushing. It is normal post-op to see slight ear pain, low-grade fever, and mouth odor. The next condition is peritonstillar abscess. This is a serious complication from tonsillitis or from pharyngitis. Signs and symptoms is like a hot potato voice. It's a muffled voice. Trismus, so they can't open their mouth. Pooling of saliva or drooling. Uvula is deviated to one side. It could cause airway obstruction, so that's why it's life-threatening. Next condition is bronchiolitis. This is an inflammation or obstruction of the lower respiratory tract. It starts as an upper respiratory infection like congestion, rhinorrhea, etc. And then it goes to a lower respiratory infection like tachypnea, cough, and wheezing. Some patients will have mild cold symptoms, and some patients will have respiratory distress symptoms. With infants, they will have difficulty feeding, dehydration, and irritability. Treatment is supportive according to their symptoms, and you could suction, oxygen, fluids, remove secretion with both according to their symptoms. So I divided the pediatric view into two. This was part 1, and the next video will be part 2. So stay tuned for the next pediatric Euro video, and for my other Euro videos. Thank you for watching. Please like and subscribe.